Occupational English Test. Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a physiotherapist consultation with Mr. Musk. You now have 30 seconds to go through the notes.
Good morning, Mr. Musk. How are you feeling today?
Morning, Doc. I've had better days, to be honest. My shoulder's been a real pain lately.
I understand. Let's dive into your history a bit. When did you first start noticing the pain in your shoulder?
Oh, it's been a while. I'd say it's been bugging me for about 6 months now. Started off with a bit of stiffness, but now it's like my shoulder's totally frozen up. Can't even lift the arm properly. Initially it was a dull, aching pain that increased as the day progressed, and pain is worse when I move my arm in any direction.
That sounds frustrating. Have you had any injuries or accidents that might have triggered this?
Not really. I mean, I did have a fall last year while I was working on one of my projects, but I didn't think much of it at the time. Just some bruises and a bit of soreness. I did rest for a few days before going back to my daily routine. Maybe that's what started it.
It's possible. Falls can sometimes lead to injuries that don't show up right away. What kind of activities do you do regularly? Anything that might strain your shoulder?
Well, you know, I work in an office 9 to 5, mostly desk job with computer. But it's not like I'm lifting heavy stuff or anything. Mostly just a lot of typing on my computer. Sometimes, I will continue to work from home.
I see. Occupation-related repetitive movements can sometimes contribute to shoulder issues. Have you tried any treatments or seen any specialists for this so far?
Yeah, I've seen a couple of doctors. They did check my shoulder's range of motion. I was asked to perform various movements with my arm. Like reaching across my chest to touch the opposite shoulder and down my back to touch the opposite shoulder blade. One gave me some painkillers and anti-inflammatory meds. Advil was the one which I took. Another one suggested physical therapy, but I haven't had the time to stick to it. Tried some home exercises, but they didn't help much.
Got it. We'll need to get a bit more information. Any other health conditions or comorbidities that we should be aware of?
Well, I do have diabetes, but it's pretty well controlled with medication. No major issues otherwise.
All right. Considering your symptoms and history, I think we should do a few further investigations. An MRI scan of your shoulder would give us a better idea of what's going on inside. We can also look into your posture and ergonomics to see if there are any adjustments that might help.
Sounds good, Doc. Whatever it takes to get this sorted.
Great. In the meantime, let's talk about some treatment options. Physical therapy is definitely a key component. We'll tailor a specific exercise program to improve your range of motion and strengthen the muscles around your shoulder. It might take some time and dedication, but it's worth it.
Yeah, I suppose I need to make time for it. Can't keep ignoring it.
Exactly. We might also consider some pain management options like heat therapy, ultrasound, or even corticosteroid injections if necessary. But let's see how you respond to the exercises first.
All right, Let's do it. Thanks, Doc.
End of Extract 1. Extract 2. Questions 13 to 24. You hear a consultation between audiometrist and Mr. Stephen about ear problems. You now have 30 seconds to go through the notes.
Morning, Mr. Stephen. How's it going today?
Morning, not too great, to be honest. My ear's been acting up, and it's driving me nuts.
I'm sorry to hear that. Let's get to the bottom of it. When did you first start having issues with your ear?
I guess it's been about a couple of months now. It started with a bit of ringing, but lately, it's gotten worse. Sometimes, I feel like I can't hear properly out of my left ear. I am doing okay with my right ear, I think. I had trouble understanding what people are saying over the telephone. On occasions, I had to turn up the TV volume so loud that others complain. Can't understand what's being said when children talk to me.
Did anything specific happen around the time you first noticed it? Any loud noises, infections, or injuries?
Well, I did go to a concert a few months ago. It was super loud, and my ears were ringing for a day or two after that. But I thought it would go away. Also, I had a cold a while back, and my ear felt blocked for a bit. I remember, my GP gave me ear drops and said I had swimmer's ear, when a few months back I had discharge from my left ear.
Concerts can definitely be tough on the ears, especially if you're close to the speakers. And colds and swimmer's ear, which is otitis, can sometimes lead to fluid buildup or infections that affect hearing. What kind of activities do you usually do? Any hobbies or work that involves loud noises?
Not really. I work in an office, so it's pretty quiet most of the time. I do like listening to music with my headphones, though. I tend to crank up the volume when my favorite songs come on.
Got it. Constant exposure to loud sounds, even through headphones, can take a toll on your hearing. Have you tried any treatments or seen any specialists for this issue before?
I saw my GP, and they gave me some ear drops called Simulacin for the blockage, but it didn't help much. They suggested I come see an audiometrist to get a better idea of what's going on.
All right, we'll get some more information through a hearing test to see where the problem might be. Any other health issues or medications that I should know about?
No, I'm pretty healthy overall. Just the usual stuff, occasional headaches and a bit of stress from work, but nothing major.
Good to know. First, we'll do a hearing test to measure how well you hear different frequencies and volumes. We may need to do tests like tympanometry, bone conduction test and others. Depending on the results, we might do further tests or recommend treatments. You mentioned the ringing in your ear. How often does that happen?
It's pretty constant. Some days it's worse than others, especially when I'm tired or stressed. It's like this high-pitched buzz that just won't go away.
That sounds like tinnitus, which is common after exposure to loud sounds. We'll see what the tests show and then discuss the best course of action. In the meantime, try to avoid loud environments and keep the volume down on your headphones.
I'll try, Doc. I just want this buzzing to stop and my hearing to get back to normal.
I understand. We'll work on it together. Let's get you set up for the hearing test, and we'll go from there. You have options like using hearing aid. There are few types like digital, analog, behind the ear, in the ear. We will see if you really need it after the test has been done.
End of Part A. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a supervisor talking to a trainee. Now read the question.
Good day, Harry. How has your shift progressed?
Good day. I encountered a challenge while administering Mrs. Thompson's for medication. I have performed this procedure numerous times, so I was reasonably confident. However, I was unprepared for the difficulty locating a suitable vein.
Locating a vein can indeed be arduous, particularly in patients with delicate or compromised health.
Yes, precisely. I suspect that her ongoing treatment has resulted in vein sclerosis. Despite my best efforts, I struggled to establish a reliable access point, which caused Mrs. Thompson discomfort.
It is indeed distressing for patients when procedures do not proceed smoothly. How did you address the situation?
I took immediate steps to alleviate her discomfort, such as ensuring she was relaxed and using a warm compress to dilate the veins. However, I was ultimately unable to succeed and had to seek assistance from a senior colleague.
It is commendable that you recognize the need to seek assistance. We shall review the procedure together to identify any areas for improvement. It is crucial to remain vigilant and act swiftly in such situations.
Thank you. I appreciate your guidance and will certainly be more attentive in future endeavors.
Question 26. You hear a briefing by nurse manager to staff of a care home. Now read the question.
Good morning, everyone. I hope you are all doing well today. I wanted to take a few moments to discuss some important changes to our policy regarding accepting gifts from patients and their families. First and foremost, we deeply appreciate the gratitude and kindness shown by our patients and their families. However, we must ensure that our professional integrity and ethical standards are upheld at all times. To this end, we have updated our policy on accepting gifts. Nurses and other staff members are not permitted to accept any form of monetary gift, including cash, checks, gift cards, or vouchers. If a patient or family member offers such a gift, please politely decline and explain our policy. Small, non-monetary gifts, such as flowers, chocolates, or homemade treats, may be accepted if they are given as a token of appreciation. If you are unsure about the value or appropriateness of a gift, please consult with your supervisor before accepting it. Any gift that appears to be of significant value, such as jewelry, expensive electronics, or other high-value items, should not be accepted. Kindly inform the patient or family member of our policy and suggest alternative ways they can express their gratitude, such as a thank you card or letter to the team. If a patient or family member wishes to give a gift to the entire team, such as a box of pastries or a fruit basket, it may be accepted and shared among the staff. However, please ensure that the gift complies with the non-monetary gift guidelines mentioned above.
Question 27. You hear a dietitian talking to hospital staff. Now read the question.
Good morning, everyone. I hope you're all doing well. Today, I'd like to take a moment to discuss important aspect of patient care. Proper nutrition is a cornerstone of health and recovery, and it's essential that we, as a team, prioritize this aspect of patient care. First, accurate assessment of each patient's nutritional status is crucial. This includes understanding their dietary preferences, cultural considerations, and any specific dietary restrictions or allergies. By doing so, we can tailor their meals to meet their individual needs. Our goal is to provide balanced meals that include a variety of nutrients, including carbohydrates, proteins, healthy fats, vitamins, and minerals. Each patient's diet should be designed to support their recovery, boost their immune system, and promote overall well-being. Some patients may have specific dietary requirements due to their medical conditions. For example, those with diabetes, hypertension, or kidney disease may need specially tailored diets. It's important that we collaborate with the medical team to ensure these needs are met. Adequate hydration is a key component of patient care. We must ensure that patients are receiving the right amount of fluids throughout the day, and we should monitor for signs of dehydration.
Question 28. You hear a senior midwife talking to trainee midwives. Now read the question.
Good morning. Today, I'd like to talk about a few aspects of midwifery. From the moment a mother enters the labor ward, it's essential to establish trust and rapport. Introduce yourself warmly, use her name, and engage in friendly conversation. Let her know that you're there to support her throughout the process. Listen to the mother attentively and empathetically. Acknowledge her fears, concerns, and feelings. Sometimes, just being heard can provide immense comfort. Avoid interrupting or offering solutions too quickly. Instead, let her express herself fully. Labor can be a daunting experience, especially for first-time mothers. Reassure her that what she's experiencing is normal and that she's doing a great job. Positive affirmations and encouragement can boost her confidence and morale. Your demeanor can greatly influence the mother's emotional state. Stay calm, composed, and confident, even during challenging moments. Your calm presence can help her feel more secure and less anxious. Keep the mother informed about what's happening during labor and what to expect next. Clear and honest communication can alleviate her fears and uncertainties. Explain procedures and interventions in simple terms and ensure she understands her options.
Question 29. You hear a tissue viability nurse briefing hospital staff. Now read the question.
Today, I'd like to discuss an important aspect of patient care, managing pressure ulcers. Pressure ulcers, also known as bed sores or pressure injuries, can significantly impact patient health and recovery. It's essential that we understand how to prevent, identify, and manage them effectively. The first step in preventing pressure ulcers is to identify patients at risk. Use standardized tools like the Braden scale to assess factors such as mobility, nutrition, moisture, and sensory perception. Regularly reassess patients, especially those with changes in condition. Perform thorough skin inspections during each shift. Pay special attention to bony prominences such as heels, sacrum, elbows, and the back of the head. Look for early signs of pressure damage, including redness, warmth, or changes in skin texture. Regularly repositioning patients is critical in preventing pressure ulcers. Aim to change the patient's position at least every 2 hours. Use pillows or foam wedges to offload pressure from vulnerable areas. Utilize pressure-relieving mattresses, cushions, and overlays for patients at high risk. These support surfaces help distribute pressure more evenly and reduce the risk of tissue damage. Ensure patients receive adequate nutrition and hydration. Malnutrition and dehydration can impair skin integrity and delay healing. Collaborate with dietitians to create tailored nutrition plans for at-risk patients. Keep the skin clean and dry. Excess moisture from sweating, incontinence, or wound drainage can increase the risk of pressure ulcers. Use absorbent pads and barrier creams to protect the skin.
Question 30. You hear a patient talking to occupational therapist. Now read the question.
Good afternoon, Mr. Jones. How are you feeling today?
Afternoon, Doc. I'm doing all right, I guess. Still getting used to this new hip.
That's completely normal. It takes some time to adjust after a hip replacement. Let's talk about your progress and how we can help you get back to your daily activities. How has your mobility been since the surgery?
It's been a bit of a challenge. I'm using a walker to get around, and my leg feels pretty stiff. But I can move better than before the surgery, that's for sure. Putting on my socks and shoes is a bit tricky, and I need some help with that. Getting in and out of bed is also a bit of a struggle. It's frustrating not being able to do simple things on my own.
I get it. Regaining your independence is important, and we'll work on it together. For getting in and out of bed, try using a leg lifter to assist with lifting your operated leg. It helps reduce strain and makes the process smoother.
I'll give that a try. Thanks, Doc.
End of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Helen Cooper about her work with young patients who are learning to cope with type 1 diabetes. You now have 90 seconds to look at the questions.
I'm joined today by Dr. Helen Cooper, who works with patients who've type 1 diabetes. Now, diabetes is a traumatic experience for patients. Helen, in your experience, how do younger patients tend to react to it?
For teens and children with type 1, the actual time of their diabetes diagnosis is often a confusing and frightening blur. They have a memory of feeling ill, being suddenly taken to hospital and waking up on a drip, surrounded by various medical staff and anxious parents. It may all seem like a nightmare, best forgotten. Diabetes, though, can't be forgotten. Unlike the usual illnesses of childhood, type 1 diabetes won't ever go away. When the child slowly realizes this, they're naturally both frightened and upset. They may long for it to be yesterday, or last week, to return to the way things were before. It is difficult to find what the child is going through.
Can you briefly talk about type 1 diabetes?
Type 1 diabetes, once known as juvenile diabetes or insulin-dependent diabetes, is a chronic condition. In this condition, the pancreas makes little or no insulin. Insulin is a hormone the body uses to allow glucose to enter cells to produce energy. Different factors, such as genetics and some viruses, may cause type 1 diabetes. Although type 1 diabetes usually appears during childhood or adolescence, it can develop in adults. Even after a lot of research, type 1 diabetes has no cure. Treatment is directed toward managing the amount of sugar in the blood using insulin, diet, and lifestyle to prevent complications. The symptoms of type 1 in children can be tricky. For instance, bedwetting in children can be normal among many children. However, it may be one of the symptoms of diabetes related to urinating a lot.
How families and children cope with the condition.
All people, and families, have different ways of coping with things, and children are likely to copy the way that their parents cope. After the physical and emotional shock of a diagnosis of diabetes, expecting a child to deal with things quickly and practically isn't helpful. This shock and the way their life has changed need to be acknowledged and talked about, allowing them to express their feelings, however difficult. No one knows precisely what the child has gone through, and they may not be able or have the words to explain it. They may blame themselves, or see their diabetes as a punishment for something. It's a good idea to let them express their fears and emotions now, as these won't simply disappear, and even if they lie buried they may re-emerge at a later date, maybe in their teens or 20s, say. Some children with type 1 diabetes may choose to minimize their difficulties, preferring not to mention it, ignore it, or play it down. Everyone finds their own way of coping, and some children may cope better than others. Be aware, though, that a child who seems to be coping very well may be hiding their true feelings.
What is the right way to support children with diabetes?
After a loss, and this is a loss, people naturally go through a period of grief and mourning. This process takes time, but is necessary for recovery and for getting used to a new and difficult way of life. How long it takes depends on the individual and how much support, both emotional and physical, is available. Allow children to grieve in their own way, and don't try to hurry them. Older children find it difficult to talk about their diabetes, as indeed do many adults. They may find it easier to talk to someone outside their immediate family, like a grandparent or best friend. It can also help an older child to keep a daily journal to say how the day was, what was especially difficult and what was good. Young children with diabetes need comfort, cuddles, and calm handling. If your child's diabetes diagnosis comes when they're very young, be aware that problems may emerge when they're older, often when school starts and your child realizes that their life is different to those of other children.
What about life expectancy with type 1 diabetes?
Before the discovery of insulin, 1 century ago, a diagnosis of type 1 diabetes, a term that had not yet been coined, was a death sentence. Newly diagnosed patients usually only had days or weeks to live. The only ways to prolong life at all were extreme measures such as starvation diets. The discovery of insulin is a story that has been told many times. It changed everything. Suddenly, almost overnight, the lives of these unfortunate souls could be saved. Living a longer, healthier life with type 1 diabetes involves making healthy lifestyle decisions related to managing the condition. By doing this, one can improve long-term prognosis. For diabetes treatment, it is important to learn how to balance blood sugar levels with medications taken by mouth and insulin. Additionally, preventing complications of diabetes can significantly impact increasing life expectancy. It is wise to talk about quality of life, rather just number of years. Uncontrolled blood glucose levels and related health complications can reduce life expectancy among people with type 1 diabetes. Despite the risks of this disease, people with type 1 diabetes can live long, healthy lives.
What about recent developments in its treatment?
Currently, the standard therapy for type 1 diabetes is with insulin. For few patients, recurrent low blood sugars can make their lives hard and lead to potentially life-threatening situations. For these patients, an islet cell transplant can offer great relief and can be considered life-saving. Broadly, islet cellular therapy is the transplantation of insulin-producing cells into patients who do not have functional islet cells of their own. These cells then replace the function that was lost when the patient developed type 1 diabetes. It is different when compared to conventional insulin therapy, which requires patients to inject themselves with insulin multiple times during the day.
End of extract 1. Extract 2. Questions 37 to 42. You hear a presentation by Dr. Shelby about multiple personality disorder. You now have 90 seconds to look at the questions.
Hi, I am Dr. Shelby. I will be talking about multiple personality disorder. Firstly, multiple personality disorder, MPD, is a major dissociative reaction in which the patient leads two or more lives independently, usually alternating. Each personality seemingly possesses the ability to function independently and separately, one in dominant position, while the other, or others, is kept submerged for a time. This reaction is the ultimate of dissociative progression. The cause of MPD is supposed to be severe sexual trauma in a child that was so painful that it must be split off or dissociated from the child. Two predisposing factors have to be present. The first is a biopsychological capacity to dissociate, usually identified with high responsiveness to hypnosis. The second is repeated exposure to severe stressful environment, as one might find in an abusive family. I would talk about a case. Let me call her X. Ms. X is a 29-year-old white married female who, after having taken an overdose of sleeping pills in her home, was discovered by her husband and admitted to a hospital. This overdose was attributed to her inability to cope with her responsibility as a wife and mother. The husband reported that several times he had found food burning in the stove. On one occasion the patient was saved from a fire in the home but was unable to recall how it started. The patient also denied ever having had a sexual relationship with her husband, although she was the mother of his 3 children. She experienced traumatic experiences in her childhood twice at the age of 3 and 9. How it was manifested can't be said as typical. There is no linear explanation. It is highly individualistic. The diagnosis of MPD is missed more often than it is made. A patient with MPD is likely to have had 3 or more hospitalizations, between 3 and 5 erroneous diagnoses, and nearly 7 years in the mental health system before the diagnosis of MPD is made. 8 criteria have to be present for an MPD diagnosis to be made. MPD patients must have a careful evaluation. Amnesia for behaviors in court is always dismissed as lying. Fugue states appear to be attempts to evade justice. Finding things in one's possession looks like stealing. Self-mutilation and suicide attempts are seen as manipulation, and the use of different names at different times and in different circumstances is interpreted as the conscious use of aliases in order to evade the law. Diagnosis is a challenge since it presents with symptoms which are not very distinct and indistinguishable from other mental health issues. When you think about multiple personalities, what is the first thing that comes to your mind? For many, it is a disturbing picture from a Hollywood film about a deranged and sociopathic murderer. Multiple personality disorder, MPD, was changed to dissociative identity disorder, DID, in the Diagnostic and Statistical Manual of Mental Disorders in 1994. The inaccurate portrayal of DID in the media has contributed to harming people living with DID. People have lost friends, family, and career opportunities because of being honest about their condition. Not only is the stigma rampant, but the public's general lack of awareness, through no fault of their own, is concerning at best. DID is a real mental health condition, and many clinicians are missing the diagnosis, especially trauma-informed professionals, because DID is a hidden condition, and few clinicians are trained in its assessment and treatment. In fact, when I was completing my own doctoral program in clinical psychology, I was told in my adult psychopathology course not to worry about DID. I was told it was extremely rare, and I would not see it in my office. The condition is not rare at all. An estimated 1 to 3% of the population lives with it, and the actual numbers are suspected to be much higher. It is difficult to obtain accurate statistics on a condition clinicians are missing, and those who do know they live with it often will not disclose on legal and medical forms that they do out of fear of repercussions. Who would want to disclose that they live with DID when the person on the other end of receiving that disclosure would begin to think they were going to be harmed or murdered? People with DID are no more dangerous than any other human beings. In fact, people with DID are more likely to experience re-traumatization and become victims of continued abuse and exploitation than they are to harm anyone else. Most with DID are more at risk to themselves should one of their parts engage in self-injurious behavior such as cutting, burning, and/or substance abuse to cope with the emotional and physical pain that, for most with DID, is the result of unresolved trauma. Another stigma that exists is around patients who have self-injurious behavior. Most clinicians immediately assume the patient must have borderline personality disorder and, without proper assessment, could be missing patients who are living with DID and who may have experienced ritual abuse in which some parts have been programmed to harm the physical body, and the self-injury is completely out of the control of the individual until co-consciousness, communication between parts, is reached.
End of listening test. You now have 2 minutes to check your answers.